Good evening, sir.
Good evening.
How are you, sir? Nice to see you back in India.
Fine.
Nice to see you back in India.
Huh?
Nice to see you back in India. Full, and you have a lot of books behind you. My God.
படிக்கணுமே உங்களை மாதிரி அப்படியே நெல்சன் அப்படியே கரைச்சி குடிச்சிருக்கீங்க. அப்புறம் யூ நெவர் ஃபர்கெட் எனிதிங்.
Good.
I'm a sincere student learning from you.
Good evening, Satish. Good evening, Satish.
Good evening, sir. Good evening.
Good evening, Dr. Satish.
Good evening, sir.
Good evening.
How are you, sir? I think trip is over now. US trip. Hello.
Hello.
Still
You're
jet
back
lag.
from the US, sir?
Sir, Srinivasan is back in
Still
Pondicherry.
lying jet lag. Getting up at 1 o'clock, watching
God.
ears open.
Oh, God.
Okay,
After
okay.
that, no sleep.
Normally itself, he's a very light sleeper.
Okay.
He gets up very early.
Team from Southern Railway Hospital. Hello.
Good evening, sir.
Yeah. Please check your PPT. Good evening.
Okay.
Just make it full screen and then again you can close it. Yeah. Now you can close it. Yeah. Good evening,
Good
Dr. Anjali.
Yeah, good evening, sir.
Good evening, madam. Just a minute, I'll take some water.
Good evening, Madam Anjali.
Good evening, sir.
Dr. Hemant and Abhisha, no? Abhiya.
Hemant Kumar, you can just talk a little so that we can see whether your voice is audible.
Yes, sir. Good evening, sir. Myself,
Yeah, fine,
Dr.
fine.
Hemant.
Yeah, fine. The
Okay.
voice is coming.
Yeah.
Dr. Bala, it's 9. Shall we start?
Yes, sir. Yes, sir. I'm ready. Ready, sir. No problem. No problem.
Yeah.
Yeah. Yes, Dr. Hemant Kumar and Abiba, you can start.
Good evening, sir. Today I am presenting the case. An 8-month-old female infant, firstborn of non-consanguineous marriage, brought by mother with chief complaints of fever for the past 3 weeks, fast breathing from the day 10 of life, and history of difficulty in feeding from the day 10 of life. Failure to gain weight since early infancy. Shall I continue, sir?
1 minute. Go back to the previous slide. Go with that. Wait. Okay. What do you mean by the term early infancy? What is early infancy? What is late infancy?
Which month you call it early infancy and beyond which?
Before 3 months, you can.
Before 3 months. I'm not sure whether it's, I mean, of course, it's all semantics.
Usually,
What I want to know,
Sir.
instead of saying early infancy, it's a very vague thing.
Okay, sir.
Somebody may mean early infancy as less than 6 months. As per assessment, somebody might say 3 months. Very difficult to define. I don't think there is an actual. Sir, please correct me if I am wrong. Dr. Anjali, you can also correct me. I don't think there is any specific definition called early infancy. Instead of that, you could have
8-month-old infant. That's
8-month-old infant from whatever date the mother had noticed.
Yes, sir.
Could have mentioned 2nd month, 3rd month, 4th month rather than early infancy. Why did you use the term early infancy here instead of giving it specifically a date or a month?
Probably he meant breathing from day 10 of life. That early had come because of that. Because, subsequently as mentioned, fast breathing from day 10 of
10 of
life.
life.
So probably that is why he has put the term early.
Female infants, right?
No. When did the first, when did the mother, whose history is reliable, they're saying that When did the mother say that she has concerns about weight gain? What period?
6 months of,
Pardon?
at the time of 6 months of age.
6 months. 6 months. So that is definitely not early infancy.
Yes.
Okay, that's why I questioned you.
Yes, sir.
Okay. Instead of that, you could have said third symptom or fourth symptom. Inadequate weight gain noticed by around 6 months of
6
age.
months.
From 6 months onwards, something like that.
Yeah,
Okay.
you could have mentioned fast breathing from early infancy. That is okay, but 10 day of life.
Okay, sir.
Okay. Please
Okay.
go ahead.
History of presenting illness. An 8-month-old female infant brought by her parents with complaining of fever for the past 3 weeks. Initially, it was intermittent, high grade, released with antipyretics. In between a febrile period of 3 to 4 days. After
One minute. Okay. See, go back to the previous slide.
Sir.
Again, always in history, the symptoms should come in a chronological order.
Okay.
The presenting complaints. Are your complaints in the chronological order or not, or reverse?
Not, sir.
Huh?
No, sir.
Either you should have only started off with fever,
Fever.
okay, and then you could have given all those breathing history as past history, or you should have started with fast breathing from 10 days of age.
Yes, sir.
When did the illness start? The illness started only 3 weeks back, or the illness started right in the newborn? Do you think the fever and the fast breathing are related to each other or not related to each other?
Related to it.
Then why are you starting from the last 3 weeks instead of from the 10 days of life?
Yes, sir. Actually, fever last 3 days was very significant.
Oh, see, you mean to say the fast breathing is not significant?
Yes, sir. Significant.
Huh? And
Significant.
the fever and fast breathing are related or not related? See, you must remember, Dr. Hemant,
Yes, sir.
ultimately, you can change your historical data
Yes,
in
sir.
presentation based on your holistic assessment. Now, at the end of your history physical examination, do you think this fast breathing and fever are related or not related at all?
Yes, sir. Related.
Related.
Yes.
Then, where should you have started the history?
Fast breathing, then comes to fevers.
I'm sure Professor Srinivasan would agree with me. Sir,
Absolutely. Yeah.
because
So
you can't disconnect the two. When
Yes,
they
sir.
are related, when they have significance, okay,
Yes,
in
sir.
terms of relationship between one and the other, you should not ignore the symptom of fast breathing and the symptom of difficulty in feeding and only start with fever.
actually, we could have mentioned that a child who was having a problem from 10 day of life is having fast breathing and difficulty in feeding from 10 days. He is having this thing, fever for the past 3 weeks. In the one sentence, you could have mentioned.
Okay.
That's one. You understand?
Yes, sir.
Please go ahead.
An 8-month-old infant brought by her parents.
Now you remove the fever history. You start from 10 days
Okay, sir.
or from birth.
Okay, sir. After the 10 days of life, mother noticed fast breathing during feeding and difficulty in feeding from the 10 days of life. With these complaints, mother came to our hospital and diagnosed have some cardiac problems.
What do you mean fast breathing? What do you mean by difficulty in feeding? When do you use the term? What is the meaning of the term difficulty in feeding? I can understand fast breathing, okay.
Yes.
What do you mean by the term difficulty in feeding?
Sir, during difficult feeding, child was breathlessness become more and child was stopping taking the feeds. After some time again, she's taking feeds, sir.
Okay. So fast breathing and inadequate feeding or decreased feeding, or PGs are fond of calling it suck-rest cycle, isn't it? Okay.
Yes.
Okay, right.
The complaints of fast breathing, mother noticed from the day 10 of life, which is gradually progressing, increases with feeding. It is now associated with chest indrawing, sir.
Now means when?
At the now admitted child was admitted, sir. Now,
Before admission, the mother has not noticed any chest in
yes, sir.
drawing.
Before admission also noticed, sir. Gradually increasing and
When did she first notice it?
last 2 months back she noticed, sir.
Before that, it was not there.
Yes, sir.
Go ahead.
Baby delivered by elective LSCS because of indication polyhydramnios with a birth weight of 2.5 kgs and cried immediately after birth. History of forehead sweating present during feeding, sir.
No. Please go to the previous slide. What do you mean by difficulty in feeding increases
Yeah.
over time?
Sir, even I wanted to ask him that fast breathing during feeding and difficulty, but what method the mother had used for feeding and what difficulty did she find? Was it a breastfeeding or was it a feeding? What is a vati chamach or palladi feeding or what?
Yes.
When was the baby they found that it had a difficulty in what type of feeding or what?
Yes, sir. Sir, actually, child was not breastfed, sir, because of maternal illness.
Okay.
PPH, madam.
Okay.
Child was bottle fed from the.
No, is it not
1 hour.
significant history? Very important. This thing.
Extremely important history.
Yeah.
Yes, sir. After the 1 hour of life, sir, started on bottle feeds. After 10 days, mother noticed that with bottle feeds, child is getting more breathlessness. Then she started an katori and spoon feeding.
Okay. So that was a fast breathing during the feeding. And what difficulty in that feeding did she find? That baby was spitting out, or what was the baby doing?
Yes, madam. Vomiting, regurgitation of feeds also there.
There were. So that coordination was not good. Or what? Sucking, swallowing.
Sucking.
Because the baby was a full-term baby, I think so, no?
Yes, madam.
Okay, so what difficulty then did the mother, or did you ask more history regarding that difficulty in feeding?
Yes, madam.
See, what is one is easy to feed, then what difficulty that mother had in feeding?
During feeding, there is a increase in forehead sweating and breathlessness during feeding. Madam. So, in between
The
child was
usual
stopping.
thing is the child will take some rest and again
She is
became
taking feeds.
show
Yes.
interest. So periodically child will stop. Okay, that is the way the child behaves. Yeah.
And the amount, doctor, how was the amount? Because
One
as the
scoop
baby
she
is
is
growing.
mixing with 1 scoop she is mixing with 30 ml of water.
Yeah. No, not that I'm asking. I just wanted to ask, is the amount decreased as the baby was growing? Did the baby take a little decrease in the amount of feed?
Yes,
or
madam.
what was, Yeah.
Yes, madam.
So I think these points you should have
Yes,
mentioned it in the history. So there was a decreased amount of intake of milk also.
yes, madam. At the 5 months of age, mother started on complementary treatment. Cerelac she started.
Dr. Hemant,
Sir.
Dr. Snehal has very correctly put in the chat box.
Sir.
First, you must know what you mean by the term feeding difficulty.
Yes.
First of all, whatever mother says if she uses the term feeding difficulty,
Yes, sir.
you must find out what exactly she means by the term feeding difficulty.
Yes,
Just
sir.
to give you an example, the term feeding difficulty can be used by the mother when she has a problem or the baby has a problem. Okay.
Yes, sir.
Just to give you an example, the mother has got a problem with her nipple, with her positioning. And in this case, you said mother had eclampsia, something like that, illness. That will cause feeding difficulty.
Yes, sir.
On the other hand, feeding difficulty may arise due to several problems in the infant. It may be a mechanical problem, a cleft lip, a cleft palate, a Peary-Robin syndrome might well cause a feeding difficulty.
Yes, sir.
Or feeding difficulty may be because of dyspnea
Yes.
or breathing difficulty due to a respiratory or cardiac or a cardiorespiratory problem. Or Feeding difficulty may be because of some systemic illness in the baby, which may include extreme lethargy due to hypoglycemia or a metabolic cause or even HIE. So anything can cause feeding difficulty.
Yes.
So you should clearly describe what the mother meant
Exactly says.
feeding difficulty. It's not enough if you simply, because you
Yeah.
mentioned fast breathing.
Yes.
Usually the mother will say, my child was not sucking well and then I was giving by this thing. So
Correct.
if we have asked, that's what she would have told, I'm sure.
Yeah. Okay. And again, you use two terms, regurgitation and vomiting. What is
Yes.
the difference between the two? You said just now.
Yes.
You remember correct?
Yes.
You said baby had regurgitation and vomiting. What is regurgitation? What is vomiting? Which is
Regurgitation is,
pathological, which is likely to be pathological. I wouldn't say which is all, it's not all, it's not, even vomiting is not always pathological. Regurgitation is something which is quite normal, physiological. Rumination, the mild regurgitation is normal
It
in
was called faucetting those days.
faucetting. It's normal in a normal baby, the newborn period. Only vomiting, that too occurring frequently, is a problem. Right?
yes.
And Dr. Anjali correctly explained, most babies have regurgitation.
Yes.
Every normal physiological. Right?
Yes.
Okay. And
Yes.
you said from 10 days it is progressing.
Yes.
Wow. How did the mother identify that it is progressing?
So initially it was less. Now it become even at rest also retractions are there.
Even at rest, it is more. And you rightly pointed out chest in drawing.
Yes.
There. Okay.
Yes.
What's the significance of chest in drawing in a young infant? How do you interpret chest in drawing in a young infant? What does it mean? The presence of chest in drawing in a young infant. What is your inference? What does that symptom tell you about the problem in the baby? Yeah, anybody can put in the chat box also. Yeah. Hello?
Yes.
Yeah, two things. You must remember chest indrawing or chest retractions or the presence of chest retractions is an unequivocal indication of respiratory distress beyond 2 to 3 months of age. 2 to 3 months of age. In fact, if you go back to the WHO ARI program, acute respiratory program in the 90s and 2000, they classified pneumonia differently from what you classify today. Now you have only pneumonia and severe pneumonia. Those days, no pneumonia, severe pneumonia, very severe. For classifying a child as having severe pneumonia, the presence of retractions was used as a criteria.
Yes.
There in the manual, it is mentioned, infants below the age of 2 to 3 months may have retractions. So the presence of retractions does not mean it is severe pneumonia. That is what was given in the WHO. The point that I'm trying to tell you is, young infants may have retractions without pneumonia or respiratory distress in the first 2 to 3 months of age, particularly preterm infants, because of the increased pliability of the chest cage. But if retractions are present beyond 2 to 3 months of age, physiologically it indicates that the lung compliance is reduced. What is happening is that normally when you take an inspiration, the ribs move out, the intercostal spaces move out. But if the lung for some reason has lost its compliance, the negative intrathoracic pressure pulls the intercostal inside, and that is what causes the retraction. That's a pathogenesis of retraction. So they are beyond 3 months, presence of retractions is a significant clue that there might be a reduction in the lung compliance of this infant. And lung compliance can be reduced by several mechanisms. For example, if you have pneumonia and the lungs are solid, compliance is lost. When there is pleural effusion, when there is pneumothorax, when there is pulmonary edema, when there is cardiac failure, lung compliance is lost. When there is atelectasis, lung compliance is reduced. So you can get retractions when there is pneumonia, you can get retractions when there is pulmonary edema, you can get retractions when there is atelectasis, pneumothorax, or pleural effusion. I hope you understood what I told you. Okay?
Yes.
Yeah. Yes. And you must, the baby is never directly breastfed. Am I right?
Yes, sir. Yes, sir.
Okay. Right. Go ahead.
History of saccharide cycle present. Mother noticed increased heartbeat while holding the baby against the shoulder. History of periorbital swelling is present. History of
anything else she felt while holding the child?
Sir.
Sometimes you can find mother will also feel a thrill. So especially they've been mentioned in books. Okay.
Yeah. History of periorbital swelling, how long? From when? You must have a time period. You cannot simply say history of periorbital swelling. The child is on IV fluid, there may be periorbital swelling.
Yes. Before medication started.
From when? From when is the periorbital swelling?
Mother was noticed at the day 10 of life. Sir.
Day 10 of life.
After starting medications, it was subsided. Even sacral edema was also there.
That you should have mentioned. Please go ahead.
History of hospitalization for fever and recurrent respiratory infections every month, admission nearly 7 times till now, needing IV antibiotic in each hospitalization. 3 to 5 days of hospital stay at every time of admission.
What do you mean by recurrent respiratory infection? What were the actual symptoms?
Fever and cough.
Okay. Was there any wheeze?
Wheeze not mentioned. Sir.
You should mention. Why it is important to mention presence or absence of wheeze? Why?
Small bronchioles in the lungs.
No. See, the same child, the mother gives a history, every time there is only wheezing and some fever, some breathlessness, or fever is not there, wheezing, breathlessness, 7 times admission.
Community acquired pneumonia.
Pneumonia? No. Why am I harping on wheeze? Anybody can put in the chat box? Okay. To make the matter simple for all of you, if you look at the difference between a viral pneumonia or viral respiratory infection and the community acquired bacterial pneumonia, studies have shown that the most significant clinical predictor favoring a viral pneumonia or a viral respiratory infection is, what is it, Hemant? Can you complete? Wheeze. The presence of wheeze makes bacterial pneumonia extremely unlikely. That's why I harp on wheeze. In fact, the most significant clinical predictor of a non-bacterial pneumonia is the presence of wheeze. In fact, Anjali has correctly put it. If wheeze is there, that means it's an airway problem. It's not a parenchymal problem. Parenchymal problem doesn't produce a wheeze. Right?
Yes, sir.
Go ahead.
No history of loose discoloration of skin and limbs. No history of abdominal distension. Baby was never breastfed as a mother had PPH and was admitted. I was in ICU. So she was started on bottle feed and was not sucking at bottle because of breathlessness in between. According to mother's perception, baby head size was small when compared to the other babies of same age group and not gaining adequate weight with birth weight of 2.5 kgs. Now she is 4.040 kgs.
No. When did the mother know that the head size was small? At birth, later, now.
Later, sir.
Later means at what age?
At 6 months of age.
So for at birth, was it okay?
Yes, sir.
Huh?
Yes, sir.
Yes, sir.
Yes, sir.
Sure.
Yes.
Now, what is the difference between two? There are two mothers. See, for example, you have two mothers. One mother says the head was small at birth. Another mother, like what you're saying in this case, says head was okay, doctor, at birth, but now I find the head appears to be small, say 8 months old. What's the difference between the two? In terms of your interpretation. Can anybody put in the chat box, please? Yes, Dr. Abiba.
It is the head size is smaller, then we can think in terms of any TORCH infection or intrauterine infection, sir, or any chromosomal anomalies also.
Yeah, if the head size is small right from birth, that indicates it's a primary microcephaly due to some lesion which has occurred in the antenatal.
Intrauterine.
Whereas a baby who has a normal head size at birth,
Later it develops.
later found to have a small head, may have a problem leading to microcephaly with the lesion occurring in the postnatal period or in the perinatal period. That is what should be. For example, you have, as you rightly pointed out, severe, there are many primary, there are many causes of primary microcephaly, which include intrauterine infections, hereditary recessive microcephaly, inherited causes, maternal phenylketonuria, maternal malnutrition, maternal drugs, maternal radiation. They all will cause severe intrauterine growth retardation. They will all cause microcephaly right at birth. Even those infants who in the antenatal period have suffered from growth retardation, ischemia, their head size will be small at birth. On the other hand, a baby may be born with a normal head size, may suffer from a disease like a lesion like neonatal meningitis, intraventricular hemorrhage, severe HIE. Their head size will be normal at birth, but later the head size will not. You must remember that most of the brain growth is completed by 2 years of age. Nearly 70 to 80% is over by 2 years of age. Right? Okay, go ahead.
Parents are aware that child has heart disease since birth, which require medication until surgery. It's parental perception. Antenatal history. Primary gravida, mother's age at the conception.
One minute. Doctor, please go to the previous slide.
Yes.
Oh. You said that there is what you call success cycle from 10 days of age. You said the mother had noticed feeding difficulty from 10 days of age.
Yes.
Is the so-called feeding difficulty coming and going, persisting and static,
Yes.
or persisting and worsening? You are not clear about it.
Yes, sir. Persisting and worsening. Sir.
Worsening. That is one. Second, you said hospitalization for 7 months.
Yes,
So
sir.
for 7 times.
Yes.
When was the first hospitalization? When was the second, third, and why am I asking that?
Duration.
Not duration.
Yeah.
See, for example, first 3 months, the number of hospitalizations, same baby, 6 times. From 6 months onwards, it's only once.
Severity of
You should exactly, you can identify that the disease is progressive.
Yes.
By giving the time frame of those hospitalizations.
Yes.
Okay, the interval between one episode and the other.
Yes.
And again, you did not clearly tell us whether the so-called retractions and the fast breathing remain right from 10 days, remain the same from 10 days of age with worsening during respiratory infection, or it appeared only during respiratory infections, completely disappeared after the infections were treated, and how it progressed.
Started on day 10 of life, sir. It was increasing gradually, sir. During now at rest also retractions are there, sir.
Okay, go ahead. Go ahead.
Antenatal history. Primary gravida, mother's age at
Anjali, Dr. Anjali or Srinivasan, you want to ask any more questions on this?
Yeah, sir. You mentioned that LRTI, how often, even that will also predict the age of the child. If the age, the CCF presenting at the age will tell you some sort of the congenital heart disease of the child. Is it right, sir? So
Absolutely.
a child presenting in
Absolutely.
1 month or 2 months will tell you that he has a severe like ASPS. If he presents in 4 months, it could be left to right shunt.
Yeah, absolutely.
Yeah, so that also history doctor you should have asked.
Yeah, because
Yeah.
what Anjali says is very, very appropriate, because most of the left-right shunts, they don't present with symptoms in the first 1 to 2 months. When the pulmonary vascular resistance is very high, it protects against respiratory distress. Only when the PVR falls down, the infant starts having respiratory distress. That happens usually around 6 to 8 weeks. Even the murmur may not be appreciated by the pediatrician in the first 4 weeks. Only during the 6 weeks vaccination, the murmur or the symptom might appear. Right? So that would be very, very relevant to mention when it started worsening. Okay, go ahead.
Antenatal history. Primary gravida, mother's age at the time of conception 20 years. Spontaneous conception. Pregnancy confirmed by UPT at the 2 months of amenorrhea. Booked and immunized. Started on folic acid from the first trimester. Started on iron folic acid tablets from the 4th month onwards. No history of exposure to radiation and drugs. No history of fever and rash, joint pains, or lymphadenopathy in first trimester. No history of PAH, GDM, hypothyroidism, bleeding, leaking PV. No history of chronic medical conditions like hypertension, diabetes mellitus, and SLE. Anomaly scan done at the 8 months of gestation showing some cardiac lesions, but details are not available with mothers.
Okay.
Natal and postnatal history. Full turn, delivered by elective LSCS, indication polyhydramnios, cried immediately after birth. Birth weight is 2.5 kg. Started on formula feed since birth via bottle and cup and spoon due to maternal illness.
Sir, I would like to ask, sir, doctor, can you tell me what drugs you had mentioned? No drugs. So what drugs came to your mind which will cause a congenital heart disease?
Sodium valproate, madam, lithium.
Sodium valproate, lithium.
Yes.
Okay.
Smoking, phenytoin also.
Okay. So these two main drugs. And radiation, any radiation will cause a heart, or it will cause a structural anomaly, and that will lead to the further complication. That what you meant, or what? Or are there any radiation specific which causes the heart disease? I don't know. That's all.
Radiation.
No, you meant a radiation, no history of any radiation to the mother. So you mean that radiation may cause a structural defect. When was the radiation taken? During the first trimester, second trimester? There was no radiation only. But can you tell me what came in your mind? Why did you ask this history? Yes, hello.
Yes, madam.
Yeah, please tell us.
Please tell us this radiation, because no, even we don't know. We will learn from you doctors. So just tell us what radiation came to your mind which causes heart disease. I have read about the drugs. Lithium will cause Epstein's anomaly and you phenytoin, and that's fine. But radiation, any particular radiation like iodine 131, 123, does it really cause any problem for the heart?
Otherwise, you can just tell what radiation causes in pregnancy.
Yeah.
Fetal abnormalities.
Yeah. So what should you have mentioned? The initial, the first part of where the organogenesis happens, that is the ovum.
Yes.
It's a ovum with 15 days, so that will on its own it will get aborted. 15 days to some 9 weeks. That is the organogenesis. So structural anomalies are more common if the mother undergoes certain radiation during that period. Okay.
Okay.
And that then may lead to functional deficiencies.
Yeah, okay.
Okay.
Yes.
But even I will have to read. Even I don't know what radiations causes. Okay, you can go further. Yeah.
Developmental
No. Previous slide. Previous slide. What was that? No, uske after that.
natal and postnatal history.
Hmm.
Full term delivered by elective LSCS, indication polyhydramnios, cried immediately after birth. Birth weight is 2.5 kg. Started on formula feed since birth via bottle and cup and spoon due to maternal illness.
Yeah. So LSCS was only because of polyhydramnias.
Yes, madam.
Okay. So what does how will the polyhydramnias affect the baby?
Bacterial vertebral anomalies.
Yeah, but why elective CS only because of polyhydramnias? Because I have never heard polyhydramnias will have what complications, doctor? So that it was an elective LSCS.
Bacterial anomalies, anorectal
Okay.
anomalies, cardiac anomalies, tracheoesophageal fistula, and renal anomalies, limb abnormalities will be there in polyhydramnios.
Okay, and main diaphragmatic hernias.
Definitely.
Okay, but LSCS for that I have never heard. I mean, up till now, my gynecologists have never told me that polyhydramnias is there, so we are taking. Sir, can you please highlight, sir, polyhydramnias, the reason for the LSCS?
Polyhydramnias. I don't know. I don't know. To be very honest, I don't know. Sir, let me ask. Polyhydramnias per se is not an indication. I don't know. It might have been mentioned. I don't know. Why should anybody with polyhydramnias by itself?
Polyhydramnias for cardiac is not.
Not sure.
Yeah.
We will find it. I will do the homework, sir. I will do the homework and I'll find it out next.
I don't know. Yeah. Please go ahead.
Oh, go ahead.
Developmental history, gross motor, neck holding attained at 5 months of age, rollover at the age of 7 months, social smile attained at the 3 months, baby follows the light, cooing present, turns to sound, midline play is present. Sir. Some developmental delay is there.
What developmental?
Yeah, where is the developmental delay, sir?
Madam, rollover at 7 months.
Rollover at 7. Neck holding attended at 5 months.
Yes, madam.
Okay, so normally it is 4 months. So there is a slight delay there also.
Yes,
then roll over by 7 months.
Yes, ma'am.
Okay, and now the baby is 8 months old.
Yes, madam.
Okay, and social smile. So in the social you went 3 months.
1 minute. Why? See, a baby can. Which is the first thing to happen from supine to prone or prone to supine rolling over?
Supine to prone.
Supine to
Prone.
No. Actually, it is from prone to supine. Babies learn to roll over first from the prone position to the supine position, not from supine to prone. Okay. And at 7 months, if the baby is able to roll over, I wouldn't dismiss it as abnormal, more so in a baby who's got some chronic systemic disease, who's not putting on weight.
Not sitting with support.
Not sitting with
support also.
That you didn't mention.
Yes.
You didn't know you're mentioning. Okay. Gross motor, there is a minimal delay. Okay. Yes. Fine. What about cooing is present?
Yes.
Any babbling?
Babbling, no, sir.
Okay. Right.
Immunization history, immunized up to 14 weeks of age as per national immunization program. Family history, firstborn, non-consanguineous marriage, no history of congenital heart disease in the cardiac problems in family members. Diet history, expected calories 800 kilocalories, baby is taking 550 kilocalories, deficit 250 kilocalories. Proteins expected 12 grams, but baby is taking 9 grams, deficit 3 grams. Was not breastfed on formula feed in correct dilution, started on complementary feeds from the 5th month of age.
No, complementary feeds means what is the feeding? What is the thing? You are saying deficient in micronutrients. Why you say it's deficient? What is the baby receiving?
Cerelac. Cerelac rice and vegetables. She's mixing with lactose and milk sometimes.
No. In what way is it deficient in micronutrients? Your formula Because always avoid using the trade name. Whatever you just now mentioned,
Yes, sir.
all of them are supplemented with all micronutrients. In fact, one of the advantages of using these infant commercial infant formulas is that they are all supplemented
Yes,
or fortified with the vitamins and minerals. For example, just now you mentioned Cerelac. Cerelac is supplemented with minerals and micronutrients, vitamins. I don't think your statement of saying that deficiency of micronutrients, if at all there is deficiency, it must be deficient because the quantity is less and not because qualitatively it is bad. Qualitatively, whatever formula you mentioned is okay.
Yes, sir.
Quantitatively, whatever the baby is receiving must be very small. That way, it may be inadequate.
Yes.
So you must be careful in saying that it is deficient in micronutrients, right?
Yes, sir.
Okay. Okay.
So
So-
when they complementary feed, sir, they should also tell us in detail, very small amount in detail, what was the frequency the child is taking. What is the texture, like the type the child is taking?
Frequency, quantity, and
8 to 10 times
different.
mother is
What
given.
available foods which are
and
available.
the katori, what is the size of this thing?
Correct. Then varieties of food, what the child is having, and what active response, there is something called as active response. What was the hygiene and what type of feeding by what the mother was giving. That all you should mention when you come on with the word as a complementary feed.
Yes, sir.
Complementary
Very
feeding during
right.
a well time and during illness when the child is admitted. That is also important.
Yes.
Very rightly pointed out by Anjali, because this baby, one of the presenting complaints you had mentioned is the poor weight
Start
gain.
getting weight. Yes, sir.
And the poor weight gain may not be only due to the systemic disease or a cardiac disease. It may be a
Inadequate feeds.
combination of factors,
Yes.
right? Go ahead.
Sir, can I just tell the students that there are certain mnemonics by which it is very easy for them to remember. In this complementary feed, nothing to do about any social area. It is called as a fatwa, FATVAH. F for frequency, A for available food, T is for the texture, what texture the mother gives, V is your varieties of food, then A is your active response, and H is your hygiene. So these all 4 or 5 things you have to mention when you say it's a complementary feed.
Please repeat it, Anjali. I will also learn from it.
My God, sir, it is fatwa, FATVAH.
Okay.
Frequency, available foods, texture, means it's a ghee-like or whatever. Then V is your varieties, what varieties she gives. A is your active response. When the baby notes their head, where she stops or doesn't she stop. And H is your hygiene.
Excellent. Very well said. Yeah, go ahead.
Okay, sir. Go ahead, doctor. Yeah.
Economic status. Mother is a graduate and father finished secondary schooling. Living in a pakka house with attached bathroom and separate kitchen with a good ventilation and corporation water facility. According to modified Kuppaswamy classifications, she falls under upper middle class family. Treatment history. Child was started on furopate and digoxin from the day 10 of life. From the past 1 month, she started on enalapril.
Now, one suggestion again. Avoid using trade names. Furosemide,
Yes, sir.
enalapril is fine. Enalapril is not a trade name. Always avoid using trade names. Okay.
Yes.
Okay.
Summary. An 8 months old female child, first born out of non-consanguineous marriage, admitted with complaints of fever for 3 weeks, with history of fast breathing, difficulty of feeding from the day 10 of life, with failure to gain weight, and success cycle, with recurrent LRTI requiring hospitalization.
So, what is your inference from this? What do you think is the diagnosis? Likely historical diagnosis.
Sir, acyanotic congenital heart disease with increased pulmonary blood flow, with congestive cardiac failure, with left to right shunt, with disproportionate failure to thrive, with delayed milestones, with fever. Most probably infective endocarditis, UTI.
Yeah. Now, the big problem, you said fever for 15 days.
Yes.
But you never elaborated about the fever.
Yes. Sir,
What?
fever.
What was the type of fever? What were the symptoms associated with fever?
Yes.
What are the treatment details for the fever for the last 15 days?
Yes.
What was the response to the treatment? Whether it was
Sir, fever of last 3 weeks, sir. First 12 days, it is high grade, relieved by antipyretics, sir. Started on ceftriaxone and amikacin, sir. After 12 days, there is a gap of 3 to 4 days ephemeral period. Then again, fever of high grade fever continues, and every 4 to 6 hours we are giving antipyretics, sir, not responding to any antibiotics.
Yeah, it's important how it was given, intravenous, and this,
Intravenous,
how often it is given. All these
Intravenous
things
and
will give an idea what the child is having.
intravenous.
Was the baby investigated for fever in the last, you said,
Yes.
fever, how many days now? 3 weeks.
3 weeks, sir.
Was it investigated or not?
Yes, sir, investigators.
So what is it? What is the fever now from your history? What is the type of fever? What's the type of fever? Was it intermittent, remittent, continuous, hectic?
From last 1 week, it is continuous fever, sir.
Continuous fever.
Yes.
Continuous fever. So what do you think? What do you label it as? Continuous fever. 3 weeks investigations, I'm sure, have been done,
Yes.
and no diagnosis yet. So what is it? What is the term that you should use? What is the term that you would use from the history? Okay, let me ask you. You won't call it PUO?
Yes.
Yes or no?
Yes.
And when do you use the term PUO? What is the current definition of PUO? Anybody can put in the chat box. In fact, it's very interesting to read literature. Sir would agree. Previously, the term FUO or PUO was reserved for those cases which have fever for 3 weeks.
Agreed.
Now, the term FUO or PUO is given to any child who has fever for 8 days
Without diagnosis.
without any obvious identifiable cause with the basic investigations or the preliminary investigation. 8 days. 8 days is the present cutoff for labeling a child as having PUO. And this is very well PUO. Because you don't seem to have any associated symptoms other than the worsening respiratory distress. Now in your diagnosis, you have to tell us a few things. One, because I asked this question in the beginning. What happened to the child after the onset of fever? Did the respiratory distress worsen?
Yes, sir.
Yeah, and whether the child was transferred to intensive care unit, that's also important.
Yeah.
Whether the child was kept in the same place or the child was transferred.
Initially, child was not on oxygen support, sir. Now, last 4 days, child is on oxygen support, sir.
That you should have mentioned. Indicating something is happening to the oxygenation or perfusion or
And inadequate response to the
Yes. treatment. Okay.
Yes.
Right. That is one. Second thing is, I don't think I will think of UTI at all in this child who has fever for 3 weeks.
Yes.
And who's requiring oxygen and who's receiving ICU care.
Yes.
Doesn't happen. That too in a child who appears to have a chronic breathing difficulty starting from 10 days of age.
Yes.
Just take one by one. Now, this infant has breathing difficulty, feeding difficulty from 10 days of age with repeated hospitalization for respiratory infection.
Yes.
And other than being a congenital heart disease, what are the other, with increased pulmonary blood flow, what are the possibilities you thought of? In what all diseases the same history can occur? I am saying this is not congenital heart disease with increased pulmonary blood flow. I am something else. Can it be?
Community acquired pneumonia, sir.
Community acquired pneumonia will it cause respiratory distress from 10 days of age?
No, please.
Now, again, you go back to the fundamentals. Go back to the fundamentals. See, basically, I would first ask myself, is this so-called respiratory difficulty in the baby or the fast breathing in the baby with or without retractions? Since you said retractions are present with retractions, is this a problem which is cardiac, which is respiratory, or which is a combination of cardiac and respiratory? Is this metabolic? Is this neurological? Miscellaneous? Okay, right. In this child, which group do you think that
Cardiac.
this child, cardiac and respiratory or cardiac alone?
Cardiac.
Huh?
Cardiac.
Only cardiac.
Yes.
But you said 7 admissions for respiratory infection.
Sir, there is pulmonary plethora might have.
Pulmonary edema, cardiac failure. Now, the other thing is, other than left right shunt,
Yes, sir.
any other cardiac illness or cardiac disease can produce any other? Can it produce the same history other than acyanotic congenital heart disease, increased pulmonary blood flow? Can anybody put in the chat box? Okay, I'll give you examples. There are few other disorders you must consider. Duct-dependent lesion. Duct-dependent lesions is cyanosis. In fact, I never heard from you whether there have been any cyanosis or not. In fact, I was just waiting to hear from you. At any point of time, was there cyanosis?
No cyanosis, sir.
Did you mention the history?
Yes, sir.
Yeah, that is one. So it is acyanotic. So other than an increased pulmonary blood flow with cardiac failure due to a congenital heart disease, you should think of a few other disorders. One, coarctation of aorta. Coarctation of aorta. A coarctation of aorta can very well present like this. Two, a congenital myocardial disease, endomyocardial fibroelastosis, or a cardiomyopathy due to a metabolic disorder, a storage disorder, can exactly present like this. Okay, so that is a differential diagnosis, right? But agreed that this is likely to be acyanotic congenital heart disease with increased pulmonary blood flow, cardiac failure. And syndromic, I don't know, disproportionate. What do you mean by disproportionate failure to thrive? You used a term, I don't know. Dr. Anjali, is there a term called disproportionate failure?
No. Even I was also going to ask him the same thing. Disproportionate only comes with your stunting where there is a short stature. And failure to thrive is not a...
Only say there is suggestion of microcephaly and failure to thrive. So I
think he meant, sir, organic and non-organic, I think so. He was meant. Could be that.
Okay.
And syndromic, even I have not heard of it. Genetic. Failure to thrive, which could be a genetic. I think he wanted to mention that.
Go ahead, present your findings. Go ahead.
Yes, sir.
Sir, Srinivasan, sir, please discuss the findings.
Yeah, let him describe the child.
Yeah.
General examination, baby in supine position, hips abducted with knee flexed, typical pit frog position, and tachypneic and dyspneic. Looks around, looks undernourished, dysmorphic faces present, like a prominent forehead and glabella with hypertelorism and depressed nasal bridge was there, and a bilateral periorbital puffiness was seen. No pallor, cyanosis, clubbing, or lymphadenopathy.
Again, show the photo, child's photograph. Because you have covered the eyes, very important, especially when you are telling.
I don't think I can make out any dysmorphism with the photo that you're showing. Sir?
Low set ears is there, but microcephaly is not there. But puffiness, of course, eyelids we have mentioned, and we don't know about hypertelorism and depressed nasal bridge. Lips seem to be normal. And chin, of course, mild hypo, but it's not very significant. Yeah.
Okay.
But of course, you find that child is having a flaring of lower abdomen and mild distension. Any hernia is there, or it is this thing?
No, sir. That is diaper.
Okay.
Anthropometry weight was 4.060.
1 minute.
Yes,
Please
sir.
go back to the previous slide. More important. Is the baby having respiratory distress or not?
It's a tachypneic and dyspneic.
The presenting symptoms are respiratory distress, but you're not mentioning anything about findings in the general examination about respiratory distress, tachypnea, retractions.
Tachypnea is mentioned, but you have to mention
Tachypneic and
respiratory rate.
dyspneic.
Dyspneic means what? Dyspneic means what?
Rate is also high, sir, and
No,
babies.
for a young infant like this, why? How do you use the term dyspnea? Dyspnea is something when somebody complains. Retractions are present, isn't it?
Yes, sir.
That is what you should have mentioned. Go ahead.
Anthropometry weight 4.060 kg, which is less than -3 standard deviation, and length is 63.5 centimeter between -2 to -3 standard deviation, and weight for length is less than -3 standard deviation. Head circumference is 38 centimeter, which is less than -3 standard deviation, and chest circumference 36 centimeter, and mid upper arm circumference is 10.5 centimeter. So
What
this
is
failure to thrive is not only because of organic, but also some under nutrition is also there.
How did you? No, I don't understand. You said failure to thrive is not only because of organic disorder, but also because of what?
Nutritional deficiency, sir.
Nutrition deficiency. I don't understand.
Because in case if the baby is only having
My first question to you: you want to call this infant as having severe acute malnutrition,
Yes.
or you want to call this infant as having failure to thrive, or you want to call it both?
both, sir.
That we don't use the term. See, in an infant who has got a chronic systemic disease, I don't think it is correct to label the infant as having severe acute malnutrition. I'm sure Professor Srinivasan and Anjali would agree.
Yeah.
This
Acute
is
malnutrition is
failure to thrive.
specifically confined to lack of this thing. Of course, here the nutrition is less. We agree with that. But there is a specific organic cause for that.
Yes, sir.
Yeah, in fact, see, always, when you use the term failure to thrive, you can always ask yourself whether the failure to thrive is because of too little in, too much out, or too much is required, or too little is utilized. In this baby, it is too little in, mainly because of the cardiac problem, right? And too much is also required. Both the things are operating in this side. For example, this baby is not receiving adequate calories and proteins.
And utilization is also less.
Yes.
Because of
yes. Correct. Too much is required because there is an increased need for calories because of the cardiac disease and the repeated infections. Both the factors are operating in this child, which are causing failure to
thrive.
You should only call it as failure to thrive. Okay? Go ahead. Go ahead. Snehal has put feeding problem already there, so nutritional problem already there, all due to chronic disease. That's what. This is only failure to thrive rather than severe acute malnutrition. Go ahead.
Vital sign, heart rate 128 beats per minute, regular in rhythm, bounding pulse volume, no specific character. All peripheral pulses were palpable, no radio-radial or radio-femoral delay. Blood pressure in light upper limb 88/40 millimeter of mercury, left upper limb 86/42 millimeter of mercury, and right lower limb 92/40 millimeter of mercury, and left lower limb 88/44 millimeter of mercury, with a wide pulse pressure is there. And respiratory rate 52 per minute, regular abdominothoracic type of respiration with intercostal and subcostal retractions. Temperature 38.5 degrees Celsius, SpO2 78% on room air, improving to 92% on 2-liter oxygen support by nasal bronchs. Head to foot examination, frontal bossing present.
Now, what is the interpretation of the previous slide? You have given so much of information.
Yes, sir.
You said bounding pulse.
Bounding pulse.
Okay. So among all this thing, what do you think bounding pulse? What condition you are thinking of? Because child is in failure, cardiac failure. In spite of it, the child is having bounding pulse. Okay. And all peripheral pulses palpable. Then you have mentioned, of course, the child is having SpO2 less. Subsequently, with 2 liters of oxygen it has become. So what condition you are thinking?
Left to right shunt, sir, with CCF and probably PDA, sir, both systolic and diastolic runoff is there, causing wide pulse pressure.
But how do you account for the SpO2 78% room here?
Pulmonary edema causing less saturation, sir.
Is there any cyanosis?
No, sir.
How can you not have? I'm questioning you. Why?
Yeah, unless the hemoglobin is low. If a child is having normal hemoglobin, 78% child will have cyanosis, isn't it?
Remember, less than 85%, unless the infant's hemoglobin is very low, you should be able to appreciate cyanosis clinically. And now I'm going to ask you, what are the cyanotic heart diseases which cause bounding pulse? What are the acyanotic heart diseases which cause bounding pulse?
Exactly. That's what I wanted to try to find out from your SpO2 being less and bounding pulses. There is possibility of a cyanotic heart disease also.
Yes, sir.
Which one you are thinking? Which can present very early in life?
Truncus arteriosus, sir.
Quite right. Right.
Truncus arteriosus, then
And
total anomalous pulmonary vein
total
may
anomalous
sometimes,
pulmonary
yeah.
venous. In acyanotic PDA and aortic regurgitation, sir.
Even a large mitral regurgitation may produce a small collapsing pulse or wide pulse pressure. A very significant mitral regurgitation can produce a wide pulse pressure, minimal increase in pulse pressure. Okay, go ahead.
Head to foot examination, frontal bone present, prominent glabella, wide open anterior fontanel, 2.5 into 2.5 centimeter, it is at level. Eyes hypertelorism present, yes, depressed nasal bridge, oral cavity normal, Harrison Sulcocene, spine normal, limbs normal, and dentition, no primary teeth or cerebral. Systemic examination, cardiovascular systemic. Inspection, no engorged veins or visible palpation in the neck. Trachea appears to be in midline. Apical impulse not seen. No precordial bulge or pulsation. No epigastric.
Just two comments. One is that it is very difficult to identify the position of trachea in an 8-month-old infant. You don't even attempt it, I'm telling you. Sir, you agree? Sir?
Yeah, absolutely.
You can't palpate the trachea. You can only palpate the thyroid.
Especially in such a small child who is sick and this thing,
Okay.
Similarly, engorged veins in the neck in an 8-month-old infant. No, I have never seen anything like that. Okay.
No precordial bulge or pulsation. No epigastric pulsation or suprasternal pulsation. No engorged veins, scars over the chest wall.
And we have to also look for clinical signs of bacterial endocarditis, both in the skin as well as in the pulses.
Yes,
sometimes we may find some pulse may be missing because of embolic phenomena. Yes.
No clubbing, no?
No clubbing, sir.
Okay.
Palpation, tracheal portion confirmed. Hyperdynamic apical impulse felt in the left 5th intercostal space, 1 centimeter lateral to the midclavicular line. Thrill in the left 2nd intercostal space, radiating to the left lower sternum and to the left clavicle. No parasternal heave or palpable heart sounds. Auscultation, mitral area, S1 loud, S2 heard, no other heart sounds and no murmur. Tricuspid area, S1, S2 heard, no other heart sounds and continuous murmur of grade 3 heard. Pulmonary area, S1 normal, S2 split with loud P2, continuous murmur of grade 4 heard. In the left 3rd intercostal space, S1, S2 heart sounds heard, loud, harsh, continuous murmur. Well-held in the Epps area, grade 5, radiated to the left lower sternum. Aortic area, S1 normal, S2 normal split, and no other heart zones and no murmur.
Yeah, two comments, two suggestions and comments.
Sure.
When you describe the findings in the auscultation, always start with the area where you have significant findings. So where should you have started first?
The left third intercostal space.
Okay, it's wherever. Okay, I would have started with the pulmonary area because that is where your murmur is very, very prominent. 1. 2, it's always better to avoid grading continuous murmur.
Okay, sir.
The murmur grading has been done by Letha,
Leave.
and he did it only for systolic murmurs.
Okay, sir.
Diastolic murmurs and continuous murmurs are not graded. You only say there is a
Thrill.
loud murmur with a thrill. Only for systolic murmurs you should grade, not for
Continuous.
continuous murmur or for diastolic murmur. 2 comments. Okay.
Okay, okay, sir.
Right. What about the loud P2? What about the splitting of the second sound?
In pulmonary area, sir.
Yeah, obviously.
I could not able to make out the A2, sir. It is loud P2 only.
Very, very important. That's very, very important. In fact, of course, I can't hear the murmur now. From the description of your murmur, I guess you will not be able to appreciate the second sound at all because the murmur will run through the second sound,
Yes, sir.
making it very difficult for you to appreciate whether the pulmonary and the aortic components are separate. That too in an infant with cardiac failure, with tachycardia, it will be impossible to appreciate the splitting of the second sound. Go ahead.
Abdominal examination, scaphoid type, no visible veins, no scars, umbilicus normal, abdomen soft, liver palpable 3 cm under the right costal margin, liver span 7 cm with rounded borders, spleen not palpable. Respiratory system, bilateral normal vesicular breath sounds heard, bilateral fine crepitation heard over the infrascapular, infraaxillary and interscapular regions. Abdominothoracic type of respiration with increased work of breathing in the form of intercostal and subcostal retraction. Central nervous system examination, anterior fontanelle open, diamond shape 2.5 into 2.5 and hypotonic, reflexes are normal. Developmental, since the baby is, there is some history in the...
One comment.
Yes,
I don't
sir.
think one should be attempting developmental assessment in this baby with
Sick child.
sick
And,
child.
yeah, you cannot do it.
You can't do it. You can't do it. It's very, very unreliable. See, baby is requiring 2 liters of oxygen.
Yeah, and that too, oxygen level is so low, we will not trouble the child.
You will not be able to find out what exactly is wrong with the baby's development if the baby's saturation is so low.
Okay, sir.
Yeah, go ahead.
Lamellar tap present, rooting reflex absent, sucking reflex present, palmar grass absent, and plantar grass present. Asymmetric tonic reflex is present. Parachute reflex not attained. Turning towards the sound is there. Pull to sit, there is no head lag. Vertical suspension.
Just leave the development.
Yeah, how can you do it? I say, when the child is so sick, will they allow?
No.
Impossible.
Okay.
Go ahead.
So, probable diagnosis.
Hmm.
A case of acyanotic congenital heart disease with left to right shunt with increased pulmonary blood flow, most probably large patent ductus arteriosus in sinus rhythm with situs solitus, levocardia with congestive cardiac failure with failure to drive and dysmorphism with developmental delay with fever, probably infective endocarditis.
Why? Two or three things. How did you diagnose PDA clinically?
Clinically, there is a bounding pulse, sir, and wide pulse pressure is there, and the apex is shifted down and out, sir. So left ventricular apex with hyperdynamic.
What are the conditions in which you get a continuous murmur other than PDA?
Aortopulmonary window.
Why not this be aortopulmonary window?
And you said there is this thing, in tricuspid area, you said pansystolic murmur. And
Continuous murmur only said that.
It's nearly impossible to distinguish an aortopulmonary window and a PDA in a young infant. The only clue will be in aortopulmonary window, the murmur may be heard a bit lower down than PDA. The PDA murmur usually radiates toward the left side of the neck. The aortopulmonary window murmur usually it radiates down rather than up. That's one difference. Second is in PDA, there may be clues to the presence of a congenital rubella syndrome in the form of microcephaly, deafness, and a cataract. If that is there, it will favor a diagnosis of PDA rather than an aortopulmonary window. Anything other than aortopulmonary window which can cause, what are the other causes of continuous murmur other than PDA and aortopulmonary window?
The rupture of sinus of Valsalva, sir.
Can this be rupture of sinus of Valsalva?
Not
Again,
likely, sir.
it is very rare. The murmur is superficial, heard lower down, and usually rupture of sinus of Valsalva is seen in infective endocarditis or following cardiac surgery or trauma.
Yes, sir.
Spontaneous is very, very rare. And the murmur is superficial, right?
Yes, sir.
You won't get long duration symptoms like this. 4. Any other condition?
AV fistula, sir.
With AV fistula. Do you think this is AV fistula?
No, sir.
Systemic AV fistula can cause cardiac failure without cyanosis. Pulmonary AV fistula will cause cardiac failure without cyanosis, but the murmur is usually extracardiac. In pulmonary AV fistula, you may get the bruit in the back of the chest or front of the chest on the right side, and not like the PDA, right?
Yes, sir.
Okay. What is the difference between to and fro murmur and continuous murmur? How do you differentiate between the two?
With the help of the S2, sir. In continuous murmur, the intensity increases from the first heart sound to the second heart sound, and after that, it is a crescendo decrescendo murmur.
Second sound is not at all distinctly heard in a continuous murmur.
Continuous murmur.
In a to and fro murmur, the second sound is distinctly heard. There is a gap between the murmur and the second sound or the first sound.
Dr. Sneha has mentioned only 5 minutes more. Yeah.
Yeah, 10, sir. We can have another 15 minutes. No problem.
Okay.
Stay, please permit up to 10:25.
Okay.
Okay? Right. Go ahead.
Yes.
Yeah.
So investigations.
What do you do? What do you do for this baby? Could you go back? You said PDA. Can this be congenital rubella syndrome?
But
again, in the diagnosis, you have not mentioned failure to thrive. You have not mentioned microcephaly.
failure to thrive, you mentioned, sir.
Microcephaly?
Microcephaly is there. Yes, sir.
You should have mentioned, because
Yes,
once you have microcephaly in an infant who has got PDA, the diagnosis, unless proven otherwise, is rubella rather than anything else.
Yes,
Not a chromosomal anomaly.
okay.
Okay? Right. Go ahead. Why do you say this is infective endocarditis?
Because in structural heart defects with fever for more than 3 weeks, unless proved otherwise, there is a possibility of infective endocarditis.
Okay, I'm going to ask you a different question. You have an infant with VSD, ASD, PDA.
Yes, sir.
Which child has got the highest risk for infective endocarditis? Which child has got the least risk for infective endocarditis?
Highest risk will be for PDA and VSD.
No. VSD.
VSD.
Highest risk is for VSD, then PDA, lowest risk for ASD. In fact, you must remember, any child who gets operated for VSD, PD, or ASD after 6 months following surgery, you need not give any infective endocarditis prophylaxis for scopy, for dental extraction, etc. right? So
Okay.
VSD is the one which has the highest risk of infected endocarditis. And the other point you must remember, in patent ductus arteriosus, what you get is infective endarteritis rather than infective
Endarteritis. Yes, sir.
endarteritis. Okay. In fact, you must remember the complications of PDA as follows.
Yes, sir.
Infective endarteritis, 1, cardiac
Just to
failure,
cardiac failure.
reversal, Eisenmenger, 4, rupture of the aneurysmally dilated
Dilatation.
ductus. Sometimes you can get pressure on the recurrent laryngeal nerve and cause hoarseness. Sometimes you can press on the left lower lobe bronchus and cause atelectasis, upper lobe or lower lobe bronchus, right? The ductus can get calcified. It can give rise to a thrombus, right? Frequent pneumonia. In fact, that's the most common complication of ductus. In fact, you have a typical history of this child getting into the hospital 7 times for IV antibiotics.
Requiring antibiotic.
Recurrent pneumonia is a frequent complication of patent ductus arteriosus.
Okay.
I'm sorry. I'm sorry. Yeah, that was the iPhone call. Go ahead. Okay, right. What did you do for this child? What did you do for this infant?
We proceeded with the investigation, sir. Hemoglobin 11.3 gram and hematocrit 34.7%. Total count 17,100. Neutrophils 55% and lymphocyte 23. With platelet 4,01,000. CRP is 11.8 and ESR 5 millimeter. Blood culture and sensitivity at 3 different sites we have sent, sir, but report awaited.
What happened to the X-ray of this child? You take an X-ray or not?
We have taken, sir.
Yeah. Please interpret the X-ray.
It is a chest X-ray AP view. Child is having a prominent cardiomegaly is there, sir. CT ratio is definitely more than 50%. And right ventricular apex, sir. Left ventricular apex. Sir.
What do you mean by left ventricular apex? In fact,
it is down and out, sir.
Down and out. See, usually, don't use the term left ventricular apex. You only say there is an apparent straightening of the left cardiac border, and you see the cardiac shadow sitting right over the diaphragm. It is not up tilted, indicating it's left ventricular enlargement. Okay.
Yes, sir.
And of course, the X-ray, I'm not able to appreciate the increased vascular markings. Sometimes in VSD and PDA, both of them will have the same findings, except that in PDA, you may get a marked dilatation of the pulmonary artery. Okay, otherwise it's nearly impossible to distinguish a VSD and a PDA. Of course, you can distinguish between VSD, PDA, and ASD. In ASD, you never get a left ventricular hypertrophy. You get only left atrial and right atrial hypertrophy and pulmonary artery predominance. So, okay. Whereas in PDA, you get a left ventricular apex. Right?
Okay.
There is not much of hepatomegaly in this.
Yes, sir.
At least from the radial.
But now the child is having prominent hepatomegaly.
Okay.
ECG with left axis deviation with left ventricular hypertrophy.
Sir, Professor Srinivasan, sir, he's an authority on ECG. Sir?
So, yeah. I think I'm hearing, yeah. Left axis deviation, yes.
Left ventricular hypertrophy.
How did you identify left axis deviation? Normally, you don't get in infancy left axis deviation. How did you identify?
With lead 1 and AVF, sir, it is lead 1 is positive and AVF.
Lead 1 and 3 itself.
Yes, sir.
Lead 1 and 3? Yeah, lead 1 and AVF, which is positive, which is negative?
Actually, both is positive.
Both is positive. Then how did you identify left axis?
With 1 and 3.
When lead 3 is negative, means it is on the opposite side. So when you place lead 1 and 3,
Lead 1 and 3 are opposite.
Yeah.
Okay. What about chambers?
Left ventricle hypertrophies, dilatations.
Dilatation. What do you mean by dilatation? How do you distinguish dilatation and hypertrophy? The ECG.
Left ventricular hypertrophy only.
No. How do you distinguish the two in the ECG? You can only say left ventricular enlargement. I don't think you can distinguish enlargement and dilatation in the ECG. Okay?
Okay, sir.
Right? Okay. Go ahead. Yeah.
This is 2D echo, sir. So first one on the right side is large PDA and size 4 millimeter left to right shin. Gradient across the PDA is 75 by 18. Dilated pulmonary arteries and dilated left atrium and left ventricle and stretched PFO right to left shin and normal LV function, normal sized right atrium and right ventricle. This is the recent one, sir. Suspicion of large vegetation on pulmonary valve, undersurface of the leaflet of the pulmonary valve, 0.3 into 0.4 millimeter size vegetation. No pericardial effusion.
Okay. How do you manage this step?
So we have sent blood cultures at 3 different sites.
How many cultures you have done?
3 cultures, sir.
Okay. Right.
And,
From different sites.
Yes, sir, at 3 different sites. And we have started on ceftriaxone and gentamicin, sir.
What is the rationale for starting ceftriaxone and gentamicin?
Because generally the most common organism causing infective endocarditis is Streptococcus viridans. So, and
So
Staph aureus.
why not treat only with ceftriaxone?
If we are treating only with ceftriaxone, then the duration will be more.
No. It's a synergism. Typical beta-lactam aminoglycoside synergism for Streptococcus viridans. Okay. But then you said that this infant has already received the ceftriaxone for quite some time.
Yes, sir.
What are the other organisms other than Streptococcus viridans which can cause endocarditis?
Staphylococcus aureus and Enterococci.
Okay. And which are the difficult organisms causing infected
What is
endocarditis?
the acronym? What is the acronym for that?
Sir is giving ACEC. ACEC group of organisms are notorious for causing difficult endocarditis. In which case you may have to use drugs like what? Ceftriaxone and vancomycin. Okay. Right.
For this child, because of the dysmorphism, we have also done karyotyping. So.
What did you find?
So it is a balanced translocation only. So between short arm of chromosome 4 and long arm of chromosome 18 at P14 and Q23 regions.
Not Downs, no?
Not Downs.
Not Downs. Okay. Will you get an ophthalmological evaluation and hearing assessment?
Fundus done, sir. Fundus normal, whereas weighted, sir.
Why did you seek an ophthalmology opinion for this baby?
Sir?
Why did you seek an ophthalmologist's opinion? What is the rationale for you asking for an ophthalmologic opinion? There are 2 reasons. One, you can pick up rubella. You can identify a slit lamp evidence for cataract. Second is that you may get Roth spots. So infected endocarditis. Okay. Sir, Srinivas sir, 10:22.
Yeah.
Listen to the cake by more questions.
Yes.
Yeah, sir. She mentioned certain syndromes also. So syndromes with microcephaly, can you name, doctor, any other? As you said, Downs. Okay, 1 second. Even Pattaya. Doctor, can you mention? What are the other syndromes? Because microcephaly and syndromes. So that's why you have to do hearing test, the vision test and everything.
Yes, ma'am.
Okay, should I say then?
Yes, ma'am.
Okay, there is another mnemonic for it. And it's very easy to remember. Rubin and Smith. These are the 2 boys, Rubin and Smith. are
1 minute,
crying.
Anjali, I'll note it down. I'll note it down just slowly. Yeah.
It is Rubin and Smith.
Go
These
ahead.
are the names of two boys. They are crying for eating corn at Pattaya.
My God.
It's very easy to remember. Rubin is Rubinstein-Taibi syndrome.
That is cyanotic disease. Usually they have
No,
tetralogy.
Okay, no, I just wanted to tell them about the microcephaly and certain
Okay.
syndromes.
Go ahead.
Yeah.
Okay, the Smith is Lemley-Optis syndrome. Then crying C is for your cry-do-cat syndrome. Then they are crying to eating E is Edward syndrome.
E is also for Ellis Van Creveld syndrome, which can cause single atrium.
That is single atrium.
Okay, yeah. Then Con is for your Cornelia D. Lange syndrome. Then on Pattaya, P is your Pataut syndrome.
Fantastic.
Just for remember, otherwise it's very difficult to remember all these micro and macro. Macro is all your lysosomal leukodystrophy, like Soto, the Alexander, that is easy. Then your cerebral CSF, your vascular and your brain points. But micro is a bit difficult. But I just wanted to ask you 2 points. Can I ask them, sir?
Please go ahead.
Yeah, when you grade this intercostal or retraction, do you also think what causes more severe retraction? So you can label them, it is a severe or mild to moderate, anywhere retraction from upper to the lower part of the respiratory system. Okay, time is very less. I will tell you, if it is a suprasternal or sternal, you mean that it is a severe retraction. The child needs immediate attention. And if it is an intercostal or subcostal, it is mild to moderate. So that please keep that in mind. And second, dysmorphic and primary microcephaly. So what are the only 2 conditions where will you see less than third standard deviation below the mean? Below the mean. What are the only two problems in a child where there is a less than 3 standard deviation in definition? One you said, na, microcephaly.
Yes, ma'am. Yes, ma'am.
And the second one? Otherwise, everything is -2 standard deviation, more than -2 below the mean. But there are only 2 conditions, more than -3 below the mean. And second is a SAM. Okay. These are for your vivas only. Just if anybody asks you, it is -3 standard deviation, only 2 conditions, SAM and microcephaly. Actually, microcephaly is also -2, but if you take in a population, in a general population, 85% will have -2. So these are all not abnormal children. And hence, the definition has included -3 standard deviation.
Well said. Well said. Yes, over to Snehal for comments on genetics of heart disease.
Sir, actually we have less time, but I would suggest micro-array in this child. This may not be a balanced translocation. If there is any loss, please see if you can do micro-array in this child so that you can get it if there is any deletion in this child. Okay. Otherwise, there are many syndromes, and we don't, we don't club like, Madam has said microcephaly, there are so many syndromes. So I don't know whether we can, we don't have time, sir. But, and I couldn't see the face, which is very typical of any particular dysmorphology, because we see the face actually on the photograph. But maybe sometime later we can discuss, sir.
That one. And other thing is, I thought with having picked up a chromosomal problem in this baby, which is not typical of any specific syndrome, I thought we should do chromosomal analysis for both the parents. Am I right?
Yes, sir.
Yes, so actually chromosome 4 we have Hirschhorn syndrome. So this is 4 and 18 she said. So we have to do a microarray first, and we should see whether it is really a normal chromosomal complement, and then go ahead and do father and mother. I think baby
father and mother chromosomal analysis normal, sir.
Okay.
So that means this is not normal. See, before doing father and mother, you should have done microarray because father and mother are normal. See, we only evaluate karyotype when there is abnormality, and balance translocation only in couples with abortion. Otherwise, we don't do it. So if the child is having with abnormality, go ahead and do with microarray, and then if you have any doubts, then go and do parent. So that is what.
Only yesterday I saw pediatric clinics in North America. November edition is going to come. That's entirely on genetics. But I just saw the topics. I got jittery. They're all so difficult. Snehal, I should go through.
Most of the conditions now we do genetic diagnosis, and the karyotype, this indications are decreasing, sir. So yeah.
PGs have a look at PCNA. I think it's upcoming. And November edition is available in the clinical key. It's available in the clinical. In fact, I want to go through leisure. There are so many chapters on genetics principles and the latest diagnosis, microarray, etc., etc. PCNA. The edition is yet to be released, but is available in the clinical key. Right?
So even Nelson, every chapter further reading mentions few of the references, so they can go and read at every system. This thing they have given in further readings, so they can go have these further readings in Nelson. Yeah.
Our Nelson is very much there. Dr. Balasubramanian, I call him Indian Nelson.
Yes.
I always say, just like Dr. M.K. Nair had written about Illingworth book. So Balasubramanian will be asked to Indian edition of Nelson, editor.
Nice presentation, sir. Nicely presented. Yeah.
Well done, Hemant and Abiba. Thank you very much.
Thank you, sir.
Yeah. Good night, sir. Yeah.
Good night.
Thank you.
Thank you.